I'm so sorry, but again me. So my second lecture will be in part of rheumatologist, and I will talk about the bioregenerative approaches, the osteoarthritis treatment. So our population are getting older, and I explained already that the cardiovascular diseases is #1 killer, but the statistic of other age-related diseases, as the osteoarthritis, also have a poor prognosis, and we can see expected the growing of this disease. And in part of internal medicine doctor maybe, I think that the osteoarthritis in part of conventional medicine was most unsatisfied results treatment disease. Why? I will explain it later, and I need to remind about that the osteoarthritis is a disease involving the entire joint, including the cartilage degeneration, bone remodeling, formation of osteophytes, synovial inflammation, and all these changes leads to the main syndromes like pain, like swelling of this joint place, and loss of normal joint function. So why, in my opinion, the osteoarthritis results was unsatisfied? Because no evidence in conventional medicine can confirm that some medicine can be effective in part chondrocytes regeneration. So all medicine which we have in our market in part of treatment osteoarthritis can only reduce, according to the WOMAC scale, according to the visual analog scale, only reduce the pain. So, but we cannot change some the structure and improve the structure of synoviocytes or chondrocytes. So, what is the reason? And I'm also very happy that the main reason of unsatisfied treatment of osteoarthritis is that there are many reasons for development of this disease. And now new classification includes the new phenotypes, which based on the reason which cause special different changes in structure of joint. And if we know about it, the results will be better. For example, metabolic syndrome drive phenotypes, the main these phenotypes based the metabolic disorder. If a patient has overweight, obesity, of course, if we give any treatment, any medicine, we cannot change the structure, right? So other synovitis drive inflammatory phenotypes is the main reason, the inflammation. So any chondroprotectors will not work. So next phenotypes, cartilage derived also. Very important then new phenotypes like subchondral bone derived phenotypes. No one from the list of treatment osteoarthritis can improve their bone condition, subchondral bone condition. Yesterday I had lecture about the osteoporosis. So in these phenotypes of osteoarthritis, present like main mechanism, the local osteoporosis, and no any chondroprotector can improve the bone conditions. That is why our patient with this type of phenotypes of osteoarthritis will feel this worsening of the condition. Then age-derived phenotype typical for general senescence, and trauma injury phenotypes. Previous classification was a secondary osteoarthritis, right? So this is a main place of affection, location of osteoarthritis, but another reason about the unsatisfied treatment of osteoarthritis, that then we start treat the osteoarthritis, but it's not osteoarthritis, it's not the degenerative disease. It is another reason, autoimmune rheumatoid arthritis. They look similar, quite similar, and in initial stage we cannot recognize, but we need to be aware about some main criteria. So in rheumatic disease we need to diagnose two main criteria of pain. First, inflammatory pain. When patient suffer, when he or she wake up with a morning stiffness, mean it's present the inflammatory character of pain. And duration of pain can answer, does it osteoarthritis or initial rheumatoid arthritis? Because the stiffness in rheumatoid arthritis lasts more than 1 hour and more. So the patient needs to do some exercises. As well as I mentioned about the spondylar arthritis. So the spondylar arthritis begins with the low back pain. And when this patient meet with a rheumatologist, so it happens the severe changes, it cannot be reversed. So any stiffness means it's inflammatory characteristic of pain. Another type of pain is mechanical. Mechanical when patient suffering pain when it starts some movement or walking. It means the degenerative process inside joint. So the main it's a morning stiffness difference, and also how we can differentiate the osteoarthritis and rheumatoid arthritis. It's location of joint affection. Typical for rheumatoid arthritis, it's proximal interphalangeal joints. And the special change inside joint surface cause the dislocation of joint and cause severe deformation. You can never see this deformation in osteoarthritis. It's rheumatoid arthritis, ulnar deviation, amyotrophy of muscles, deformation like swan neck, and deformation like button loop, or both deformation like swan neck, button loop. And also the rheumatic nodulus, not character for osteoarthritis. So for rheumatoid arthritis is character the bone erosion, which not character for osteoarthritis affection, and cartilage destruction. Other osteoarthritis which can be caused and can be looks like the gout arthritis. So for gout arthritis also the typical localization, and only late stages we can see the visually the tophuses, the uric acid accumulate inside around the periarticular tissue. So if we have the metabolic types of osteoarthritis with high level uric acid, how we can help this patient by chondroprotector? No, it's impossible. That is why very important, the first it's a diagnostic. The typical localization of joint affection for rheumatoid arthritis, it's a carpometacarpal joints, proximal interphalangeal joints, as well as for the osteoarthritis, typical the distal affection. And this is typical Heberden nodes, typical only for osteoarthritis, and Bouchard nodes. And repetition is the mother of learning. So, do you know this famous painting? Yeah. How do you think? What type of osteoarthritis? Sorry, there. This is a proximal interphalangeal joint. So the Mona Lisa with rheumatoid arthritis. Yeah. Okay. So Michelangelo, this thumb. So it's typical for gout arthritis. Yeah? These women, the Monet picture, proximal interphalangeal joint, so rheumatoid arthritis. And three graces, it's with even with deformation, you can see. So It's a rheumatoid arthritis, yeah. So I explained why it's very important, the correct diagnosis in initial stage, all these phenotypes, osteoarthritis. It's the key to correct treatment. And in part subchondral derived phenotypes of osteoarthritis, it is very important to know that the osteoporosis, I explained yesterday and can repeat who cannot visit yesterday our session. So the osteoporosis, it's some condition of bone which caused due to the deterioration on bone mineral density. And in this part it includes the high activity osteoclast and low activity osteoblast. So this balance causes the bone resorption. So no one chondroprotectors can treat the bone resorption. That is why if patient has the initially mechanism of bone-derived osteoarthritis, cannot help any chondroprotectors. If you have some senescence-associated phenotypes of osteoarthritis, it can be involved all mechanism of senescence which talked about today and yesterday. So what we have in part of convention medicine, this is a slide which can reflect that first place it's exercise in any guidelines or ORC or ACR or every. So then non-steroid anti-inflammatory medicine and intra-articular corticosteroids. But I need to emphasize very seriously that intra-articular corticosteroids should be used only in case severe synovitis. It is contraindication to use the corticosteroids injection if absent synovitis in dry arthritis, because this methodics can cause now improvement, but further it can even more severe affect the synovias. So, but I will need to emphasize this: no one symptomatic slow action drugs of osteoarthritis or CSADOA, this is like name of chondroprotectors, have no improvement in clinical research. So the next stage, it's a hip replacement, right? So what we have, which approaches we have in part of bioregenerative medicine? It is PRP therapy, yeah? It's very easy, withdraw blood, then blood should be centrifugated. Then this is a platelet-rich lye, which has the anti-inflammatory properties and also due to some growing factor decrease the inflammation and improve condition. But we talked about the organ-specific treatment. That is why the new option, it's really perspective in orthopedic, in rheumatic disease, stem cell therapy. Why? Because different types of stem cells. And we talked about what does it mean, pluripotent stem cells. So the main principles, it's organ specific. And that is why the mesenchymal stem cells have shown the so successful results in treatment of osteoarthritis. Why? Because the mesenchymal stem cells is mother for cartilage cells, for bone cells, skeletal and smooth muscle cells, because it also includes in definition of joint. That is why we are happy that we have other mesenchymal stem cells in our market, and also we should know about the source of mesenchymal stem cells. It should be own stem cells, but we need to remember that stem cells age same with age of donor. And we need to know about the types of transplantation. So if you transplanted some skin, for example, from trunk to arm, it will be auto. Allo between different members of the same species. If different species, so it's a xenograft. What are the main mechanism or action of stem cells? First of all, it's anti-inflammatory, so it's decreased activity of inflammatory cytokine, also growing factors which can it can repair the cartilage. As well as in case of subchondral bone-derived phenotypes, so the mesenchymal cells is the mother for osteoblast, which can restore the bone after bone resorption, as well as a hemopoietic for osteoclast. So if we use the mesenchymal stem cells, why it can treat other cartilage, other bone, so we can cover all these phenotypes. And it's really evidence-based list when the treatment of stem cells had the successful effect. It not only decrease the scale, grade of pain patient or WOMA criteria scale, but improve the cartilage, structure of cartilage, which detected by MRI and even other methods during arthroscopy, for example. But we need to be aware about some advantages and disadvantages of stem cells which on our market. Because embryonic stem cells as well as the induced pluripotent stem cells has a tumorigenic potential. It's very important to be aware about it. And mesenchymal stem cells, disadvantage, it's a limited number of cells because main source is adipose tissue. If no adipose tissue, no stem cells. And we need to be aware about the main barriers to transplantation, like immunogenicity, I talked about it, arrhythmogenicity and engraftment. Exosomes also very successful results treatment of exosomes because it can repair the subchondral bone as well as repair the cartilage due to that they can carry special microRNA which help to rejuvenate the chondrocytes. And it's really evidence-based, so it's really clinical trials, even phase 2 exosomes, which the positive effect in degenerative meniscal injury. So we need to know that we can use the exosomes as a periarticular, as a intraarticular, and we need to be aware about the contraindication. It is very important to know that we have the absolute contraindication to any injection and relative contraindication, for example, like anticoagulant therapy in patient with diabetes, with immunosuppressed patient, and after this we can be aware and we have the good results. So what will be next step? Also confidence. Thank you for your attention.